Welcome, friends, to our next Transforming Chaplaincy webinar. It is great to have you with us here today. And if you're just joining us, I'm going to turn this over here to the Director of Transforming Chaplaincy in just a moment. In the meantime here, I just want to mention, if you're not familiar with Transforming Chaplaincy, it's great to have you for this webinar. Again, it's called Boundaries and Dual Relationships in Chaplaincy Care. And we have our research networks that are available to all of you. Please check out our website, Transforming Chaplaincy. If you have some questions for our presenters or any of the respondents here throughout our, you should have an option for the questions and answers. Please submit that. As it indicated perhaps to you as we began this broadcast, we are in presentation only mode. So we do appreciate the engagement and the interaction, but it happens via you sending us your questions. So without further ado, I didn't think I even introduced myself, Chava, but my full name is Paul Galeshoot. Even though the screen indicates I'm Andy Andresco, Andy is our former project coordinator. He has transitioned to a new role in a new organization, and my role is as the Assistant Director of Engagement. So without further ado, to you, Chava Salaji, the Director.
Hey, good morning, good afternoon, depending on where you are. Welcome to our webinar. It's so great to have this topic of discussion for today and a presentation from our colleagues from the United Kingdom. Pleased to welcome Mark Newitt, who serves as the Secretary for Healthcare Chaplaincy at Free Churches Group UK, as well as a chaplain at Sheffield Teaching Hospital, NHS, and St. Luke's Hospice in Sheffield, United Kingdom. Welcome Chris Swift, with more than 30 years in chaplaincy experience and chaplaincy work, and the past president of the College of Healthcare Chaplains, the professional body for UK chaplains. And I also want to welcome Alex Shapiro, who's going to be the respondent and the conversation partner in today's webinar. Alex is a healthcare chaplain working at the intersection of spiritual care and population health at Atlantic Health System, and also part of the 2-year demonstration project to develop spiritual health collaborative care model within the ACO at Atlantic Health. I would also add that she's also the co-convener of the Transforming Chaplaincy Outpatient Spiritual Care Research Network. And thank you all three of you to be here today, and look forward to the conversation and the presentation. So we'll start with Mark and Chris, the presentation, and then transition into the conversation.
Thank you. I'm just trying to work out if I can share the screen so I can see slides. So let's.
Yes, we can see your screen, and
there we go.
Slides are coming up. Perfect.
Yeah.
Right. We can see it. Go ahead.
Great. So yeah, so thank you for the welcome. It's great to be able to be sharing our thoughts around this topic. The roots of this presentation go back nearly a decade. I was looking back at emails today, which were from 2016, and it came out of a reflective practice session that happened within the team at Sheffield Teaching Hospitals, where a chaplain brought a case, which is where the article came out of for discussion, that led over a number of years us exploring that and trying to sort of produce an article out of it. So the article, which was published in Health and Social Care Chaplaincy, explores in more detail the issues around boundaries that first surfaced in that reflective practice session. And as we wrote the article, we realized that the issues around boundaries were not significantly addressed in chaplaincy literature or in codes of conduct. So our plan for our time today is to provide you with a little bit of background to the case that the paper developed out of before exploring some of the recommendations and the reflections that we have in that article. In particular, I want to draw attention to the tensions that we found between definitions and understandings of pastoral care that view it as having unstated and flexible boundaries, and the clear position from professional bodies that boundaries help the effective functioning of caring and supportive relationships. And as part of that, we'll link in with an article that was published around the same time as our paper, which comes from a very different direction, but actually there are some really interesting parallels within it to our recommendations and findings. And that's Kiltzman et al. And an article called Exiting Patient Rooms and Ending Relationships. And then for the last part of the presentation, I will hand over to Chris, who's going to look at links with another article, which is Harvey et al. Elicitation Hooks, a discourse analysis of patient interaction in pastoral and spiritual care, which I think also helps draw out some of the reasons why boundaries within chaplaincy might be harder to manage than they are in other professions. And then we'll look forward to Alex responding and the discussion that might develop out of that. So firstly then, some backgrounds about the case and where this developed from. So the case that our article comes from began when Tracy, and I'd say all the names of both the chaplains and the patient here are pseudonymized, asked a midwife to contact Chaplaincy after being admitted to the labour ward following a preterm pre-labour rupture of membranes in her 23rd week of gestation. Tracy was admitted for ongoing observation, and her admission lasted 69 days. Overall, as you can see, the chaplaincy database records 9 different chaplains going to see Tracy on 69 occasions, which involved nearly 45 hours of chaplaincy time. As summarised in the table, we recorded 60 interventions, with 9 occasions when Tracy either declined a visit or was unavailable. 2 of the interventions were instigated by Tracy requesting urgent support, and the remaining were part of planned ongoing chaplaincy care. On at least 3 occasions, Tracy was seen by 2 different chaplains on the same day. And excluding the out-of-hours urgent interventions, over 10 hours of Alex and Elliot's chaplaincy contact is recorded as having taken place outside of our core hours. And then as we explored this case, Alex recounted being aware of visiting on more than the occasions recorded in the database. These visits also took place outside of the core hours of our work. Alex viewed it as visiting in a personal capacity, and that's something we'll touch on as we go through the presentation. And so he did not enter those details in the database. So within the article, we explore some of the expectations around pastoral care and chaplaincy that led Elliot and Alex to have this pattern of excessive visiting and visiting beyond the bounds of our core hours. I won't go into details of those now, but in short, while they are not mutually exclusive, the reflections of Alex and Elliot can be understood from 2 perspectives. Firstly, albeit in different ways, each acknowledged that there were normative expectations and hint at or suggest that the breaking of boundaries is required by the authenticity of caring. And then secondly, again in varying ways, the visiting is rationalised in terms of not being work, but friendship. So we'll come back to that notion of friendship when we come to dual or multiple relationships. But what I want to explore here for a moment is the underlying tension that we found between understandings of pastoral care, which are being unstated, the boundaries being flexible or unstated, and that clear position from chaplaincy bodies that boundaries help in setting and making safe, effective caring. So Boyd and Lynch, for example, suggest that pastoral care boundaries in comparison to counselling or other listening services are typically left undeclared and are more flexible than those in counselling. I think that view would be echoed by others. So Mark Cobb, for example, writes about chaplaincy care being wide-ranging and often relatively unstructured, informal and irregular. It's perhaps worth pointing out here that also, perhaps contrary to some sort of talking therapies, I think chaplaincy, it's the use of the self is much more seen as being sort of permissible, and self-disclosure being part of the way that chaplains might work. Ewan Kelly writes that the greatest asset which any of us have to offer another is ourselves, or to be more precise, our reflective selves. And I see this also reflected in the new ACPE outcomes and indicators, where, for example, in relation to spiritual formation and integration, the introduction describes how fulfillment of these outcomes will lead to a healthy use of self that integrates these areas to positively impact the provision of spiritual care. This is a slight aside, but one of the things that I often do if I'm reviewing a document is do a word search and see how many times words come up. It can make for an interesting, quick, though admittedly crude way of seeing what a document might be prioritizing. And so those ACPE outcomes and indicators use the word self 15 times, but they also use the word boundaries 11 times. And in relation to the, I suppose, the relationship or that tension between the two, they have a phrase that I think is helpful, where they say that empathy and relational boundaries work in tandem to ensure helpful rather than harmful spiritual care. But that does bring us to the question of boundaries. So all the chaplaincy codes of conduct that we consulted when writing the article were clear that boundaries matter. So the UK Board of Healthcare Chaplaincy, its code of conduct, for example, states boundaries enable the effective functioning of caring and supportive relationships. And then in relation to those boundaries, it states that chaplains should observe personal and professional boundaries in your practice that sustain the integrity and rights of those in your care. Very similar statements are made, for example, in the Association of Professional Chaplains, in Spiritual Care Australia documents, and in the Chaplaincy Accreditation Board in Ireland, just to name a few. But noticeably, in all of these codes, there is a lack of descriptive clarity on what that means in practice, what it means to hold effective boundaries or hold boundaries. As might be expected, each of the codes states that chaplains should not display sexualized behavior towards those in our care. That's as far as they go. And perhaps remarkably, none of the codes mention or explore dual or multiple relationships in any way. If you're not sure, a dual or a multiple relationship refers to the holding of one or more kinds of relationship concurrently with the same person. So acting as both chaplain and friend to Tracy, which is what Alex and Elliot viewed that they were doing in some ways, and one of the ways that they justified that visiting outside core hours would be an example of a dual relationship. The role of friend bringing with it different boundaries to the role of chaplain. Within therapeutic or pastoral care roles, multiple relationships are a contested area, and there is an extensive literature that comes from other professions. And the link here is where someone has drawn together a range of references of such literature, and I had a quick scan through it and dropped it into an Excel spreadsheet to make a quick way of counting them all, and there were nearly 450 references. Now, I've not read through all of them, but I have I've read some, and in preparing the article we found also some useful summaries of the views. And generally there are two opposing ways of thinking about multiple and dual relationships. So some authors advise that they are inevitably harmful and should always be avoided due to the risk of conflicts of interest, of misuse of power, and of blurred boundaries, risking the therapist using or losing their objectivity. Others, though, are more positive. They draw attention to how a pre-existing relationship may help engender trust, as well as giving a more holistic understanding of a person's situation. And those who do have that more positive view tend to point out that in some situations, multiple relationships are unavoidable. And as Zur, for example, writes, there are types of multiple relationships which are clearly a normal part of healthy, interconnected and interdependent communities. From the writing that I reviewed, this seems to be particularly so in rural communities, but I think it would also hold in situations where chaplains are recognised as a faith leader and have a role outside of healthcare. And that, I suspect, is the case probably for the vast majority of chaplains, but particularly for those who may be working part-time and so have a real distinct role in a faith or a belief community and in a healthcare setting and community. Now, one of the best guides on dual roles that we found for the article came from what's called the Churchill framework. It was produced in partnership with the Association of Christians in Counselling and Linked Professions in the UK. And it talks about dual relationships in two areas: in domain C, which is about self-awareness and reflective practice, and then in domain D, in supervision. So in terms of self-awareness, as you can see on the slide there, it says be aware of issues surrounding dual relationships. So its practitioners are expected to have an understanding and of the tensions that may arise between different helping roles, to understand the ethical importance of avoiding them where possible. So even where it's, say, this aspect of even where people have a view that it's allowable, there's always caution expressed. And then making sure that there is an openness and an awareness of what's going on and that being shared. So talking about maintaining appropriate boundaries and bringing it into supervision, which is where, as you'll see in domain D, is mentioned. So reflect with a supervisor whether role boundaries have been crossed or blurred. So it's, again, it's done with awareness, and it's not done without that being shared and talked through with someone. So there is always that openness with it. And that brings us on to supervision, which I was glad to see referenced in that document. My belief is that with any profession that undertakes work that involves relationally complex situations or emotionally challenging situations, then supervision should be the key mechanism for the assurance of quality, including safe practice. And looking at the guidelines and the codes of conduct for sort of related professions, the British Association for Counselling and Psychotherapy actually sets supervision standards for those who wish to be registered with it, and then it actually audits, which was interesting to see the quality of that supervision, checking that people are having supervision as much as they say they are having. Spiritual Care Australia sets required levels of supervision for chaplains depending on factors such as the hours worked and the context they are working in, although there doesn't appear to be any auditing of that supervision. The Irish Chaplaincy Accreditation Board states that all healthcare chaplains are expected to avail themselves of professional supervision. But supervision, interestingly, was only mentioned in the APC and then in the UK Board of Healthcare Chaplaincy codes in relation to matters of confidentiality and maintaining it. And actually on its website, the UK board writes more of supervision in terms of developing professional identity rather than having anything to do with quality. So within the article, we argue that it would be wise for more formal supervision standards to be set and audited as part of the way that the chaplaincy develops as a profession, and that as part of those codes of conduct, we would look to see guidance around dual roles and relationships being produced that would be similar to those in the Churchill framework. Our sense when we were writing this is that we feel that such supervision and such reflection might be particularly important early on in a chaplaincy career. Within the article, Alex talks of how that he maintained contact with Tracy from a previous encounter through social media, but notes that that's the only time that he has done that. And this, the first encounter happened within his first year of being appointed as a chaplain. I've written elsewhere about an early formative experience of mine of supporting a patient coming to the end of their life, and of making a decision to go and visit them at home, even though our contract didn't extend into the community. And again, one of the other authors of the paper recalled visiting a patient in their home early on in their chaplaincy career. Each of us in our discussion when we were reflecting on this felt that we wouldn't discount the fact that we might do so again, but for all of us, that was the only time that had happened. And obviously, there's a need to be careful with conflating correlation and causation. But one understanding of the fact that it only happened on one occasion, and on each time that was early on in the chaplaincy career, is that alternative ways were found of managing the boundaries as we gained experience. So I want to now just draw onto that some links with this other research paper that came out around the same time. So this was research that was carried out through interviews with 23 chaplains about the questions and the challenges they had regarding how to end visits and interactions, and that might be individual conversations, but also how to end an ongoing relationship with a patient or their family. And in part, the article came out of the author's recognition that unlike providers in other fields who follow prescribed or predetermined lengths of visits and relationships, so you might have the counselling hour or the fact that someone will be referred to for 6 sessions or something, chaplains commonly have far more flexibility. So that recognition again of that flexible nature of chaplaincy care. And they note that how chaplains manage these flexible boundaries is not something that's explored in the literature. And they suggest to understand the various aspects of chaplaincy boundaries and interactions with patients and families is an important thing to look at to help chaplains in training think about those issues and how they might be able to best address the challenges that those bring. It's interesting that they also make the recommendation that early on in a chaplain's career, they may need to be particularly careful about how they manage boundaries. I'd say they note that the literature about chaplaincy does not appear to have examined counter-transference issues, and say that the profession might benefit from doing so. And that's where they say particularly for chaplains in early stages of their career. My doctoral thesis was about looking at chaplain support to bereaved parents, and I was writing it about the time where a couple of my friends were going through training for one to be a Gestalt counsellor and one to be a clinical psychologist, and I was struck by how much work they had to do around transferences, counter transferences, in contrast to very little having happened in my chaplaincy training. It's not something that we explicitly address in the article, but we do say that as part of managing boundaries, it's important for chaplains to reflect upon their motivations for visiting particular patients, why they might be drawn to see some rather than others, and would view such awareness as helping to both optimize workloads, but also to reduce risk of burnout. And then as a last reflection to me, before I hand over to Chris, this is not in the Kiltzman paper, but something that we touch on briefly in our boundaries paper, which is the suggestion that chaplaincy has been shaped historically by Christian clergy, and many chaplains continue to move into working into a chaplaincy role from a pastoral role within a faith and belief community. In such contexts, it feels like dual relationships are probably much more likely and may even be unavoidable. I can just think, if you are a minister of a church and you have young children, the chances of you building relationships with families that you might have met on the school run, who may come to your church, but even if they don't, may then, because they have a relationship with you, come to look to you for pastoral support when they are in times of difficulty, facing crises of particular, for whatever sort of crisis it might be, but may look to someone for that help. And then it just seems that it might be quite possible that that church-based model of working has been carried across into chaplaincy without it ever really being properly explored or reflected upon. Perhaps particularly as the notion of chaplaincy as a distinct profession has developed, it's just one of the things that hasn't really been looked at, and therefore we argue in the article that it would be a good thing for boundaries to be part of, and discussions around boundaries to be part of all chaplaincy training, and maybe a regular feature within supervisory or oversight meetings. So I'm going to stop there, and I'm going to hand over to Chris, who's going to look at another article where there are some really interesting aspects that tie into questions around boundaries in the way that chaplains work. So thank you, Chris.
Many thanks, Mark. Hello, everyone. Yeah, just to begin with a question really to follow on from aspects of what Mark's been sharing with his work is, are there things that are unique and peculiar to chaplaincy about this? It is possible to imagine a member of nursing staff, for example, having connection with a patient or a patient's relatives outside in the community. It may be more so that is the case in certain forms of chaplaincy, but I'm wondering whether there is something else. And that, to begin to look into that, I think to pick up on Mark's point about the flexibility of the time in which pastoral care is provided. So there isn't a counselling hour. I think generally speaking in chaplaincy, it is the iterative process of pastoral care that shapes and develops to some extent the chaplain's understanding as to when it's the right moment to end an episode of care. But generally speaking, there are not tight regulations or guidance about that. I was speaking to a new chaplain recently providing some supervision, and there was a very interesting little excerpt of her experience, which I thought related to what I now want to say, which was that this chaplain had been talking with a patient on a hospital ward. In the UK, we do have side rooms for care, but we also have bays that may have 4 patients there. And this chaplain was speaking to the patient, providing pastoral care, and a nurse came along and sort of joined in with the conversation. And the chaplain found it quite difficult to politely get the nurse to remove himself from that situation. And it occurred to me as I listened and reflected on that, that perhaps it was difficult for somebody passing the bed to perceive that a professional conversation was taking place. And the chaplain may well have felt it inappropriate for the patient, for the chaplain to say, "Excuse me, I'm performing a spiritual care intervention," or something along those lines. And that brings me to the paper that I want to refer to now, which, as Marcus said, is called Elicitation Hooks. It's 16 years old now since the publication of this paper, but I feel that it highlights one aspect that has an effect and impact on boundaries that we really haven't explored a great deal, and probably warrants considerably more exploration within chaplaincy. And Harvey is now a full-time academic. The piece of work he did around chaplaincy was part of his PhD, but his discipline was academic health linguistics. So this is, as you may infer from that, people who spend their time as academics looking at how nurses talk to nurses, nurses talk to doctors, doctors talk to patients, and so on, all the allied health professions and so on. And this particular student of this field decided there's somebody else on the ward who speaks to lots of different people. That's the chaplain. Let's have a look at the chaplain's linguistic technique. And the paper, there's an awful lot that is weak about the paper. He observes only the work of one chaplain, but it is somebody who's from outside the world of chaplaincy observing chaplains' communication interactions with patients primarily. So there's a small number of interactions which are studied as part of this work. But what Harvey concludes is, and is fascinated by, is that the chaplain is using ordinary everyday forms of language and communication, but with a clear and explicit purpose, at least for the person observing. So the title of Elicitation Hooks comes from this particular discipline of health linguistics, and it refers to the fact that the chaplain uses language in a way that is very effective at getting people to open up and tell their story. Their story is elicited by the forms of language, and as you might imagine, silences are looked at, non-verbal forms of conversation, ers, ums, whatever, they're all looked at as well by Harvey in order to understand what is happening with something which superficially, a bit as I mentioned about the nurse at the beginning, somebody just thinks, oh, there's a couple of people having a conversation. I'll join this conversation in a way that they wouldn't do if that had been a physiotherapist or a doctor or a nurse, probably because those forms of language that would be being used, as well as other signifiers, would have certain clear technical aspects of discourse. And what Harvey found, and the other people contributing to the paper, is that that didn't happen. But Harvey is adamant in this paper that something actually more sophisticated is going on than people who tend perhaps to resort to technical shorthand when they're engaging in conversation with patients. It does remind me, as was mentioned at the start in the introduction, I was president of the College of Healthcare Chaplains in the UK. Because we have a nationalised system of healthcare by and large, things like pay are decided for the whole of the country, for the whole of England, as it is now since devolution. And in 2003, a very sophisticated major piece of work was done about pay for employees of the National Health Service, and chaplains were part of that. But without consulting the professional body, the people doing this in the Department of Health went and just asked two chaplains about what they did. And the chaplains, perhaps rather naively, and I'm sure nobody on the call would do this, but they said things like, well, we chat to patients. Well, as you might imagine, that didn't have a very beneficial outcome in terms of the pay negotiations, and we had to retrieve a rather poor position and make it stronger, and one that was going to work in terms of employing people. But it was interesting that even chaplains themselves didn't understand the kind of sophistication about their language and discourse which Harvey identifies within this paper. Harvey is still working in academia, and I've tried to initiate some further see whether he'd be interested in doing some further and more sophisticated work around this, but unfortunately I wasn't able to do that. But it does strike me that given how central communication is to the practice of chaplaincy and spiritual care, I wonder whether we've really done enough to actually understand, with the aid of a discipline that specialises in this aspect of chaplaincy, what it is that is going on, so that, if you like, I know work is being done on taxonomies and things like that for chaplaincy, which are all laudable and very commendable. But I think there could be a risk of technical language bleeding into the chaplain's pastoral care that perhaps wouldn't be as effective as continuing what Harvey identifies within this paper of the chaplain's unusual use of language, but very effective use of language. And the reason I'm saying all this, I'm going to shut up in a minute so we can have some questions and discussion, is that I wonder whether part of the issue and problem around boundaries at times for chaplains also relates to the fact that language may not create that professional divide, if you like, which sometimes exists between other healthcare professionals and the patients who are receiving care, because it's not immediately obvious, perhaps, that something of a healthcare intervention is taking place. Harvey's not doubting that's the case, but is saying there is a sophisticated use of everyday language by the chaplain that enables that facilitation, that elicitation of the patient's story to be effective. So I think I will stop there and hand back.
Wow, there's just so much rich material here. I feel so honored to get to talk to you today a little bit, dive a little bit deeper, and to hear questions from the audience. And if anyone hasn't read the article in Holy, I really suggest it. What I was so moved by is that you're using a case study in a very different way, right? To offer ask really important questions and also offer some advice for folks who are interested as, you know, practical chaplains in the field about how to begin thinking about supervision and dual relationships, and pointing to some really wonderful discourse that's happening. I wanted to start off talking a little bit about supervision, which I think you're highlighting a really critical pain point, that we have the shared sense that, of course, our work is difficult as chaplains, right? And post-COVID, there's been this real push to that we need support groups. And chaplaincy organizations in the US have been offering different ways of providing support, coming together in support groups. But I wonder if these support groups really address this pain point in our work, really address our suffering, you might say, as chaplains, that that, as you were saying, supervision is not just about developing well as a chaplain, but also about how well we do our work. And so I was curious about your thoughts about supervision. Like, what might that actually look like for folks? I mean, I can imagine it a space where we consist in groups of people, perhaps with a supervisor or one-on-one, that we actually, you know, utilize our reflective selves, think about holding the paradoxes of our work, and wondering if there are next thoughts about how you might structure supervision and what's being done in the UK as you understand it.
Do you want to answer, Chris, from a Methodist Homes perspective to begin with, and then I will sort of chip in?
Yes, so as Mark alludes to, there quite a bit of my recent chaplaincy experience has been in social care, particularly the residential facilities for older people, and work for a charity that employs 140 chaplains. Most of those chaplains would work in isolation. They wouldn't have a professional peer, which was a very big challenge because the services were highly distributed across the country. Very often people were not close to another chaplain working in the same area. I think it is one of those things, particularly since COVID, that it may not be ideal, but using remote forms of communication as we are today offers the opportunity either of one-to-one supervision, but I think importantly group supervision and people being able to see and hear other people's experience as well as their own. In terms of boundaries, I think as Mark mentioned, with kind of codes of practice and so on, having an awareness and recognition that those boundaries exist, and at times perhaps they feel more porous than perhaps we would like, because they connect back into our domestic situation, the communities in which people live, is certainly one of the ways, I think, of helping and encouraging people to manage those boundaries in a sensitive way, but also in a way that makes sure they don't stray too far from what are appropriate boundaries or enter into relationships or connections that ultimately become unhelpful or indeed unsustainable. You know, if you want to continue relationships in that area of work I was in, it would be with the families probably of former residents. You can't keep adding on people to that workload of connection and communication. So I think sometimes people need to be encouraged to recognise their own self-care within the maintenance of boundaries.
Yeah, I think you asked about what the situation was in the UK, and it would be very mixed. So there would be some teams where whether it's clinical or pastoral supervision would be an expected part of the chaplain's continuing professional development, and the trusts would be paying for that. In other places where chaplains might have to pay for that individually. I know of one trust where actually the trust has employed someone to work as a clinical supervisor, and so the expectation is that all the members of that team will go and see this person to receive supervision, and all those questions around boundaries and other aspects of working, I guess, would be caught up in that. I think within supervision, there's often people talk about sort of the three sort of phases or three aspects. So there's normative, formative, and restorative. And I think good supervision covers those aspects. So it's looking at, you know, is the practice normative? Are you doing what might be considered good chaplaincy, or are you straying somewhere into where some of these boundaries might be being stretched or flexed? The formative, the aspect of the learning that comes in from it, and then this is where it ties in with some of the things that you were saying around, I guess, support afterwards, that you have that restorative aspect, so actually about checking in, am I looking after myself? And I guess looking after yourself is as much a boundary that's important to keep as any other in that way.
Absolutely. And I'm wondering too, you touched on how it might impact training, and I was reflecting that my CPE supervisor in my chaplaincy training, he was actually a psychoanalyst and a chaplain, and so he brought a lot of that approach, that kind of training, and we were really, it was emphasized really early on that we should not self-disclose really at all in our training, which was very complicated in our work clinically. And I was often frustrated, and it created all kinds of awkward situations. But what I realized is that it actually developed a really important muscle for me. So once I became a professional chaplain in the field, I was able to modulate that muscle, right? Like I had confidence in that I didn't need to share so much explicit detail about myself in order to connect. And so I'm wondering about other thoughts you all have about training, education.
Yeah, and it's interesting you're talking about CPE, because obviously CPE isn't established in the UK as a training route, and I think one of the strengths of CPE is that the way that it sort of forces you to look at how you are bringing yourself into a relationship with other people, and I guess when people are training through CPE, you've got that very strong supervision that's happening. I suppose the question is then what happens after that, and that's perhaps where the UK might not have that so strongly in terms of the sort of initial training, but there is perhaps more of that emphasis on ongoing supervision. And the conversations I've had with people from the States is more that you finish the CPE and then there may not be sort of ongoing supervision. So I think there's a balance to find between them. But I think particularly any reflecting on practice and that being an important thing, and doing it, which is the other, I think, strength of CPE, that you do that in a group. So it's very sort of immediate. You're doing it with peers, so you get that range of conversations that happen. Whereas unless you are doing group supervision, which is obviously sort of possible, but certainly training in the UK does emphasize reflection on practice, but that tends to be what's going on in your own head and your own writing on that, and that being read by someone who's marking it, as opposed to someone offering a sort of critique within a CPE cohort in the way that would develop.
Just to add, Alex, I very much like the idea of having that muscle and making the judicious decision about when to use it, when not to use it. Because I think one of the differences is that many chaplains, this won't apply to all, but are not, in a sense, private individuals. So if I visit a patient, they potentially can go online and see me preaching a sermon.
Sure.
Now that sermon will include views, theological views and other views, and in a sense that is what we live with, that perhaps not all other professionals know in the same way working in healthcare. So I think that's why perhaps other professions would think this is really easy, that you don't disclose anything, but actually it just doesn't work quite the same way for those kinds of reasons.
Well, it reminds me of spiritual care itself, right? That we're constantly holding these paradoxes, right? And holding them in relationship with patients and families, and yet we need to attend to those paradoxes in our, in our own work, in our, intrapersonally. I wanted to ask you one more personal question, which is Beatrice Beebe was an infant researcher and psychologist, and she talked about how research is me-search, that it actually reflects our quest to heal ourselves. And I think about chaplaincy research in a slightly different way, that it's perhaps me and we search, like our quest to heal ourselves, but also the whole world. And I'm wondering where you all are, like where you each are in this quest, and what future research might look like for you. Two-part question.
Oh, it's a difficult question. It's a good question. It's a difficult question. I mean, I think for me, certainly, getting a fuller understanding of what is happening in spiritual care and its value has a political consequence for the future of chaplaincy, particularly in the UK, where so much of it is state funded. If there's no evidence of value, how do you communicate that? How do you retain something which I know from practice, that's the me bit of it, I suppose, that the places I've been in chaplaincy, it has been incredibly important to people at certain times and made a very big difference for them, that they've been able to receive that at a traumatic and transitional part of their own life story. But then that needs to be communicated elsewhere to the people who make the decisions about funding and so on. So I think I would love there still to be chaplains when I might be in hospital in the future, but that can't be taken for granted. And I think the research offers one way, and a very, very important way, of communication and understanding that has political consequences as well as practice consequences.
Yeah, I often go back to, I think it's Daniel Grossamet's phrase of the black box of the chaplaincy intervention. And I guess some of that's what Harvey et al. were managing to open up. What is it that's actually going on in an encounter? And I think it would be fascinating to do more work around that. But I also just think the ability to shadow and actually see another chaplain in action is a really interesting possibility, and it's used so much in other medical professions, but it's not used as much as you might think within chaplaincy. So I think there's a real interesting challenge for us to do that. I think for myself, and this ties a little bit in with what Chris was saying, George Fitchett did a couple of webinars for chaplains in the UK at the end of last year on spiritual distress, and he noted that there was no research evidence from the UK that directly addressed spiritual distress, and so I think that would be a really interesting piece of work and something I would be keen to be involved with. Of can we find some markers around levels of spiritual distress with patient populations in different areas, because I think that starts then to answer the questions that Chris was saying in terms of the sort of political questions of showing that we need chaplains because there is this distress, and then being able to show that the interventions that we make help reduce that distress.
Wonderful. Good. Well, I wanted to, Paul, are you there? Do you want to open it up to the audience as well? I'm not sure I can see audience questions. Oh, here's Chala.
Hey, we have a few audience questions, so I'll try my best to loop them in the conversation. One question is about dual relationships with hospital staff. The person is pointing out that avoiding dual relationships is relatively easy and makes good sense with patients and families. For me, it's a little bit more muddy with hospital staff, since I both work with them as part of the team and provide care for them as a chaplain. What are your thoughts about these type of situations?
Yeah, I think that it perhaps happens a little bit with other professions, but not so much. So I know that within the hospital where I do some of my work, there is a staff wellbeing service that will involve being able to be referred to see physios, for example, so that they may have that sort of dual relationship of providing care to another staff member who's potentially their friend. But I suspect it's more common in chaplaincy. I think the same principles that are there in that Churchill framework would hold, of recognizing that there are some tensions around it, and has it become too complex? Do you need to refer on to someone else and say, actually, I think it would be better for another chaplain to see you and to care for you, or at least recognizing it. So if you're in a team, sort of being clear with someone else that you are doing this, and you have these two relationships with it. And I guess also there's a key aspect there, isn't it, of checking it out with the member of staff of that, and are they clear, which hat that you're wearing, and so that sense, if you bump into them if you're a friend, when you bump into them outside of work, where are the boundaries in the conversations, and is it held just in terms of what's going on in work, or might it seep through? And yeah, just having reflected on it, and where the tensions and where the boundaries might need to be permeable, which is, I think, is also sometimes a helpful way of thinking about boundaries, as opposed to this sort of rigid structure, but perhaps like cell membranes and that sort of osmosis permeability.
Yes, I think just to add very briefly, if I may, Mark, after that, I mean, in many professions, you would see somebody make an appointment, it would be an allotted amount of time. I think one of the strengths, but also one of the challenges around boundaries for chaplaincy, is it's kind of peripatetic pastoral care. You're there on that ward in the middle of the night in delivery suite or neonatal, and you are ostensibly there to support the family. But of course, there are staff there often who are upset by what's taken place, and you're providing care with them as well, but you're also a colleague, and colleagues tend to share a little bit at least about their lives. So I think there's a a balance of integrity and authenticity around that, which again, it's not necessarily easy, but I think it can be done successfully.
Thank you. I think that's just an excellent question to bring that piece around as we continue working with the person and providing care at the same time. The other question is somebody's pointing out that in their hospice experience, they agree that supervision needs to be sought out, but it isn't provided by the organization that employs the chaplain, which I would assume it's the case for most healthcare institutions, at least in the US, that unless the chaplaincy department builds into their life together, there is not like time protected. There are no structures built into from the organizational standpoint. So I just wonder if you have any thoughts around that, how that works within one's organization where they're employed and outside seeking consultation and supervision.
Yeah, I think there's a challenge for it'll be again in the UK that, as I say, there's a real difference between different trusts in what support is given. So even if you're employed, some trusts will allow opportunity for that. Others might allow you time but not pay for it, and others, it's allowed and paid for. So there's a difference there. I think it's some ways of trying to look at what's possible. Chris talked about the ability of online. So actually earlier today, along with another chaplain, we run what we call pop-up reflective practice sessions. So they happen once a month. It's an hour. It changes time, changes days, but that just means that people can come together, have an hour, and we start off just there. Then there's a pro forma that people can use to try to get ideas down, but it's really a case of just saying what's here in this room, and so yeah, but people can try to find ways to reflect together. And I think particularly if you're it's great if you're in a team that's got 6, 7 chaplains, you can create time to do that. If you're a single chaplain working somewhere, or even if you're in a team that's got a huge geographical spread, which might happen in the UK, actually finding time to come together can be difficult. So yeah, a couple of possibilities of doing things in that way.
Yeah, thank you. One quick question, if you can have a few pointers. A great question about what are your thoughts, presenters, about who makes a good clinical supervisor? The person asking a question adds, my clinical supervisor is a consultant psychiatrist who has a good understanding of spirituality, faith, and I have found this incredibly helpful. So what would be your criteria look for a good supervisor or a good consultant?
I think it depends partly on your experience and what you're looking for. Previously, I used to see someone who again had a sort of counselling psychoanalytic background because I wanted to have someone challenging me around questions of transference and those things. When I moved to work in a hospice, I actually changed supervisors because I wanted someone who had hospice experience, because I guess I wanted more of that sort of performative, normative aspect. So it perhaps, yeah, depending which aspects of normative, performative, formative are you, restorative are you looking for, and that might depend on where you are in your career and what else is going on.
I agree with Mark, absolutely. I mean, I think probably the biggest mistake is to think that all chaplain supervisors, let's say, should be senior clinical psychologists. I think the right person might exist in a number of different roles, depending where you are, and that, as Mark has said, I think we've been talking about boundaries. We also need supervisors who can stretch between those boundaries, perhaps of faith practice and commitment and formation, and also the skills and knowledge of psychology, or indeed spiritual direction and those sorts of things. So that it's probably a kind of person, not necessarily a type of role.
Thank you. I love this conversation. Unfortunately, we are at the end of our time today. Thank you for bringing your insights and your research and your experiences here. Sorry for not getting all the questions, excellent questions we got from the audience. The recording will be posted on YouTube, so feel free to refer back to it or share with other colleagues who might be interested. Thank you again, Mark, Chris, and Alex for being here today, and take care.
Thank you.